It's now my pleasure to introduce our first speaker of this morning, a woman who has been an extraordinary leader, both in the United States and around the country, in terms of her knowledge, her passion, and her care for juvenile myositis patients. She's a member of our medical advisory board. She is the head of the pediatrics department, the chairman of the pediatrics department at Duke University Hospital. It's my pleasure to introduce you to Dr. Ann Reed. Ann.
You can probably do it quicker than I can. Hi, good morning. I really have to say that it is a true honor to be standing up here in front of you today. I've seen and been a part of this organization since it began, and I have to say that I've watched it grow, I've watched the passion, and I truly walk away being inspired, and I walk away gaining so much more than I feel like I could ever give back to you. So I want to thank you for that opportunity. I also have to say that I've watched this board grow, and the work that's been done by all the people mentioned has really been amazing to help target where you should go, to be able to really advance what we're doing. And so I was asked to try to talk and just give a very brief, very high-level overview of areas of research that we really feel have made an impact in the past years. And so I just want to share some of those areas with you. The first area that I want to share is actually, so I'm going to do this before you see my slides, so I might go back a little bit when the slides pop up. First area that I think is really key has been team science. It's a term that you will hear these days, is why is it important for us all to work together? Thank you. You got it? I was just going to put it on. Awesome. Thank you. All right. Thank you. So first is team-based science, or team-based research. Now, what does that mean? Really what it is that we know that in this day and age, the amount of information and the expertise in information is so broad that people need to work together to see results. I think the past way that we did research often was an individual program would do experiments or to do some kind of component of the research to report on the patients that maybe they saw and what the outcomes were of those patients. We know that in this day and age, we need to do this together and especially broadly, especially in conditions like this that are quite rare. And to do this, then we can capitalize on people's expertise that are across disciplines, and I'll share a little bit with you what I think has been some of the most important components of this in recent history. The other one is I'm just going to briefly mention the advances we've done with understanding the autoantibodies we think are associated with myositis. We're learning a lot every day, and this will change in a year and in 2 years, so we'll continue and learn and be able to bring that information back. Also, there's been some really nice progress made in understanding what the actual tissue involvement of myositis is and really what that means in terms of outcomes potentially and how to treat patients. And then also the advances in looking at markers of disease activity and your biological, your genetics of who you are and maybe what that means in terms of your disease. So let me just go back a little bit historical. So before 1950, we didn't have steroids, and we know that dermatomyositis, particularly juvenile dermatomyositis in children, really could be a very devastating disorder. And so after the onset of being able to use steroids, there was a dramatic change in terms of what children, how they could live, decreasing all the side effects that they had from their condition. It was really dramatic, and it was noted that the steroids had to be started at the beginning of disease. That was so important, and not to delay or to wait until a child's already had some complications of their disease. Then we move forward to what we call the present time. The present time really is our recognition that steroids are great, but steroids have a lot of complications and side effects. We need to look at what we really can do to maximize our therapies and what we can do to minimize side effects and the morbidities and complications. And this has really been the era where other medications were started, methotrexate, cyclosporin. So we're talking about the last 20 plus years. So this isn't in the last few years, but this has been a while. But I think what many of us in this area realize that we all kind of did things a little different. There wasn't a group that got together 20 years ago and said, this is what we're going to try. So we realized that we were all approaching things somewhat different, which made it difficult then to be able to really compare studies, to compare between institutions. We were all over the board. And so this really came up to what I think is some of the most important progress we've made in what I call team science, and that is groups coming together nationally and internationally to try and to truly come up with how do we study patients? What do we do with your children in terms of what we measure? When do we know that there's been a change in disease activity? And so the first group I want to acknowledge is IMACS. Are you getting a lot of feedback? Because I am up here. No? You're okay? Okay. IMACS. It's a group of international physicians, scientists that have come together, it's like almost 17 plus years ago, to say we absolutely need to measure the same things and look at things the same way, so that if I want to compare my work to Dr. Huber's, we can compare that work. And so this group got together and has been perfecting these measurements of looking at what does it mean to have active disease, what does it mean to have improvement in disease, what does it mean to have worsening in disease. And they keep perfecting these measures, and this is, as I said, has been a long process, yet we've actually made some huge gains in really being on the same page, understanding what we should be doing to be able to measure disease activity. And so what they came up with years ago, and again, this continues to be refined, is a group of what they call domains. The agreement was across this broad group of individuals who take care of children with juvenile dermatomyositis is that we all have to be measuring the same things. We have to measure activity, disease activity measures, what kind of strength measures. And so this has been updated. It says MMT, which is a manual muscle testing, and probably many of your children have had a CMAS, a different type of scoring system now. What about just measures of function? Like what's daily function? So this CHAC is a functional measure that you get asked questions. Can your child get up in the morning and do things? What can they get on the bus? Things such as that. Laboratory assessments, and then all the other findings that are not muscle-based. So the extramuscular are the skin findings, your lung, potentially arthritis. And so we're going to get on the same page with how we measure and how we define a change in disease activity. As you can imagine, this is very useful when we're studying across centers, but also just in day-to-day management. It's really nice to have some definitions of what the experts really feel are changes that are impactful changes, a real change in disease activity. And so by this group coming together, one of the aspects that we were mandated to do when we got our early funding by the National Institutes of Health was to have a clinical trial. And we were mandated to that to actually test these measures that we developed. They wanted to know, does it actually work when you actually study patients, when you actually get in there. And so this trial was the rituximab and myositis trial. And truly, this was the use of the drug rituximab in patients, adults and pediatric patients who had refractory disease, individuals who weren't responding to our traditional therapies. And the beauty of this was that we collected a huge amount of data on individuals as we went along in this trial to really look at, first of all, that does the drug work, and at the end of the day, almost 83% of these patients got better, met our definitions that we said that they were improved. But we were also then able to collect data on who improved, how quickly did they improve, and how could we tell that up front? How can we tell? And we've been able to, and there's multiple papers that have been published saying there's a certain subset of patients that look like they respond very quickly to this medicine, and there's patients that respond very slowly to this medicine and not as much. And so that actually helps us up front if we have that information, say, chances of getting better might be here, somebody else's chances of getting better might be very different. So you can actually have an educated discussion around whether you should use these meds. Another group I want to highlight is CARRA. You've probably heard a lot about this, the Childhood Arthritis and Rheumatology Research Alliance. CARRA also is about as old as IMACS in many ways. This is a North American consortium of pediatric providers for children with rheumatic diseases. Really, their mission was to prevent, treat, and cure rheumatic diseases. And really what they wanted to do is to be able to start with looking at how do we treat patients. And really look at how do we come together as a team and actually try to define some best ways to treat and really look at differences that exist based on subtle changes in how we're treating. So this group came together, and I like to share these slides with people because it really helps us sort of understand the variety of treatments that have been out there over the years. So this is a study that we did where we actually gave cases to people who took care of a lot of children with dermatomyositis. So they were really experts in the area. And we said, how do you treat patients? And these are, all the different lines show you are different cases by how severe the condition was, but the colors basically share all the variability there was in treatment. So these, again, are people who grew up in the same era, many of them, and it was amazing, all the differences and combinations. We needed to get a handle on this. We also knew, this is showing you the different ways people use steroids, prednisone, IV methylprednisolone. People were all over the board with what kind of doses we were using. So we as a community came together, and this is again the team science, and said we need to define what are acceptable best practices that the experts felt that most people would be willing to start with and to follow, and that's what we've done. This is just an example of one of those best practices where we have patients who have what we defined as a moderate to severe disease course. And we actually had 3 different treatment options for individuals to choose. And then we had these pathways that said if somebody wasn't doing better, what would you do? If they were doing great, what would you do? And if they were unchanged, what would you do? And by doing this, we've been able to then limit all that variability that's been in that mix so we can compare different sites. And CARRA has allowed us to start collecting a lot of that information so that you go to your doctor, and if you're part of the CARRA registry, then all that information gets captured. So at the end of the day, we can start comparing. Does it really matter that you have IV steroids versus just oral? Does it really matter that you add IVIG into the mix? Do you really get a better outcome at 2 months and 6 months and other times? So it's really important for us to do this. These are 4 of the consensus treatment guidelines now that have been created. Adam Huber has been a huge leader in this and really made a lot of it happen. So moderate disease activity, patients who have primarily skin disease, or as you might see with some of your children, when their muscle disease goes away, their skin disease still stays quite active. That's another one of the pathways. So we can hopefully, in the not too distant future, be able to get this information put together and actually say, no, this is better treatment than this. We're recommending that people go on these same kinds of treatments. So this has been key. The other thing that I think most of you, it's probably very close to home, is that we also want to know what to do with steroids. You start taking oral steroids often, and the ability to decrease that varies between institutions as well. And I think Adam led a group that really came to consensus around how do you wean steroids, how often, how much, so we're doing things consistently so we can really see what the best thing is to do. The beauty of this too is if the physician feels or the family feels or the patient feels it's not working for them, they're having too many side effects, you just stop doing it, you change it. It's okay. But we know that we're going to get a handful of people who follow this so we can really make direct comparisons. Another thing that I want to say about team science is there's been a group internationally that's looked at what should we do in terms of evaluation. It differs from place to place. This is a group that's been led by Liza McCann out of Liverpool in England and come up really with recommendations about when a patient is seen, what information really should be collected on all patients. It allows us then to compare these data across sites again, and it was internationally derived. So if you think about that, the thousands of patients we could collect data on a year really would be impactful with us making a more appropriate progress in terms of timeline versus waiting for years to collect that number of patients in maybe one center or a few centers. The other area I think there's huge advances is in the autoantibodies. You've heard about it, you're going to hear more about it. This to me has really been important. I think it has really allowed us to open doors to know, first of all, what do these mean? And also, what does it mean in terms of how long to treat and what kind of clinical symptoms would an individual have? So we look at these antibodies, and they've been able to allow us to kind of bucket, if you have this antibody, bucket the clinical symptoms. The groups such as anti-synthetase, which the most common one that you hear about is JO1. In children, you'll see PL12 as well. Into a different bucket than patients with necrotizing myopathy, where you actually get degradation of the muscle. Amyopathic dermatomyositis, meaning really initially you don't have a lot of muscle involvement, it's mainly skin involvement, and then the muscle can, even over years, start to progress. What are those antibodies that are associated with it, and what are the ones that are associated with a pretty pronounced rash that maybe you'll develop calcinosis or vasculitis as well. So these antibodies, we can then sort of lump together clinical features. There's a group here that we know if you have one of these antibodies, we need to watch for lung disease. We know it can develop sometimes rapidly, sometimes not so rapidly, but it allows the clinician now to really focus in on saying, we need to pay attention to this and target this. We have others that have the really severe skin disease. These might be those children who go into one of those pathways of treatment that have now been defined to say, which one should different autoantibody patients go into? And then there's others as well. So this has really gained it's really progressed in terms of our knowledge. Oops, I'm missing something. Also, the other area that I think we're taking steps in is understanding what the muscle biopsy shows. If your child had a biopsy, often the physician said, this is what I think your child has based on just looking at their skin rashes and hearing their history. But we know that we see a lot of variability in muscle biopsies. So there's been progress made, and you can see this in this picture. So let me walk through. So here, So here, each one of these sort of circle kind of shape is the muscle cell. And what we see, and they're all pink on this slide, but what you see is their varying ability of these dark spots, and those are the inflammatory cells that come into that tissue. Look at this. You don't see many of these inflammatory cells in here. There's very few. There's a lot here, and we know they're all around blood vessels. We also know in this condition that there's some of these cells that get really small, and also some of them that actually they die off because of the invasion of these cells as well. And so there's been progress made looking at this and trying to correlate what we actually see in the tissue with what the outcome can be also. How can we use this information to say, we're now kind of staging or grading what's in the tissue to help us also predict what the outcome's going to be in terms of strength, maybe are the muscles weaker and smaller, and also your response to therapy and treatment. And one of these studies, Claire was the individual who led this study, but there's been a tool developed where they actually grade what that looks like in the tissue. And when they grade it, trying to use that to predict how someone's going to do. And they took this a step further and also looked at it with the antibodies. I mentioned these antibodies, and this again are people developed antibodies on one side. Now people are looking in the tissue and they're coming together with information to say, let's do this together as a team to really see what we can do and how impactful it is. So for example, patients that have the antibody MI2 have a very high score in their muscle tissue, a lot of inflammation, a lot of other changes. But they know if you have that combination that you respond extremely well to traditional therapies versus patients who, with other antibodies like MDA, that don't respond quite as well. And so we're using this information together to try and even move things forward in a much more rapid pace. The other thing are our biomarkers. As many of you probably know, we use enzymes and as one of the laboratory tests. It's probably the main laboratory test people use to really look at disease activity. However, none of the laboratory tests that today are available, whether it's enzymes or other things, really are uniformly present in all individuals. And over time, many of them go away. And we don't even see abnormalities, but you still can have a lot of active disease. And so there's been a whole flurry of new markers of disease activity, which have been much more sensitive and specific, looking at changes in muscle disease, skin disease, and other aspects of disease. So there's a whole group of these. This is just showing you one such study that looked on the left here is how active is the disease, and the line as it goes up really suggests there's a really strong correlation with activity of disease and these markers that have been developed. This is something we absolutely need to get more out there, and again, it's working across groups to be able to accelerate this work. This also holds true in saying, what about those markers of disease activity from the last slide? Now let's add in autoantibodies. And what this shows me, and this all it's intended to do is we have my antibodies at the bottom, that there's different levels of these markers based on what antibody you have. So now we're getting we're more closely looking at a precision medicine type of approach to how you're treated. If you see these aspects and you see different levels of these biological markers, and we know what antibody you have, you know, okay, you're much more likely to have these pathways or activation of certain immune responses going on. The other area I want to touch upon is genetics and genomics. Heard a lot about it. I know many people are giving samples, and their children are giving samples today to think about what could we do with this in the future. Well, as a kickoff of that IMACS group, there's a group called Myositis that was developed to really look at the genetics and genomics in disease activity. And this is one study that came out a few years ago of adult and pediatric patients with dermatomyositis. And really what they found, and this is, we love to call this a Manhattan plot because they say it looks like Manhattan, but you know, use your imagination on that baby. What was found in this is that we really found one real association with disease, and that's in the genes called the HLA genes. We've known that association for 25 years or 20 years. It was a lot of the work I did initially when I was training as a fellow. We described much of this work, and we looked in families, and we were able to identify these genes. We haven't yet gotten sophisticated enough to really understand why they're involved with disease, and then also look at some of these other things that maybe have a little bit of an association, but actually add to it or amplify what these other genes are doing. And so it's really important as we move forward. This was a accumulation of many sites across the world to get this data. It's really important as we move forward that we do this together, because if we can collect and we can look at large number of individuals and really do some of this work, we maybe can get down to more factors that are actually causative or factors that are perpetuating the condition to continue or to move on. So again, it's a way that we work together, coming back to that team science approach. So let me just take this is my personal view of next steps as well. So we talked about the genomics. That's at looking at that study, that Manhattan plot or a GWAS study. We've got that. We're maturing in that area. People have been doing this for a while. The technology is maturing in this area to say, what are your genes? You know, what's in those genes that make somebody or predispose someone to get this condition? We also know, and people have been doing work in what we call transcriptomics. What that means is which genes are actually translated to proteins. That work's also been going on for a while, and we know that's part of some of those scores for biomarkers came out of this kind of work, where we saw what genes are being turned on in the disease. Not always what's causative, it could be, but sometimes it's why is the disease going on? Why can't we stop the disease? And that's where that area comes in. The other area is called proteomics. So you hear all these omics. It's a common theme in medicine these days. This is what proteins are sitting around, what proteins are increased or decreased. And then lastly, it's metabolomics. That's actually an area where you're almost looking at the chemicals that are in the body. And I don't mean outside chemicals, but lipids in the body and other factors that we know influence the rest of these. And I think the real next step is that we need groups to come together, groups that are experts in these areas, to bring this information together. If you wait for someone who's an expert in genomics then to learn transcriptomics or proteomics and do it, we're talking years. Instead, why don't we use the expertise that's sitting out there with people who can do this and take this information and integrate it. Really, data integration is huge and modeling is huge. It's a lot of information. So we need to work with people who really are savvy in mathematical statistical modeling, and we have to come together as a group. But to me, this is where the most advances are probably going to be in terms of us understanding the disease and being able to really look forward to a cure and a treatment. So thank you for your time. I'm happy to answer any questions.
And you can take one question.
Okay. I can. Oh, yes, ma'am.
I think because we're running a few minutes behind, what we're going to do is
for all the presenters that are coming up, you all have these index cards. So there's index cards around that for each one of the presenters, if you have any questions in that, we've got a Q&A session that's scheduled for 11:30 that we'll have them up here on a panel. So I think we'll be able to get back on schedule if we put the questions on here, and any questions that you may have from Anne from her presentation or any of the others coming up, then we'll take them as a part of that. But thank you,
Thank you.
Anne.